Good morning, everybody. Good morning, everybody, and thank you for joining us. Before I turn the podium over to the heroes we have with us this morning from the public health system who are on the front lines of the MPV response, STIs, and HIV, I have some quick opening comments. Just a quick reminder to everybody as well, we're mindful there's a White House press conference on MPV at 11:45 a.m., so we will seek to finish by then so you can all cover that event as well. This has been a very disappointing week. As of last night, the Senate has rejected a request by the Biden administration for $4.5 billion to support MPV response, otherwise referred to as monkeypox, despite our community's best efforts to bring a sense of urgency to members of Congress. Today, despite falling cases, this funding is still urgently needed to fund STI programs at health departments and STI clinics who are on the front lines of treating MPV patients. There are also urgent research questions facing our community about MPV, and funding for research was included in that supplemental budget request. Let me be clear, this is unacceptable, and our community will continue to fight for the resources we need as Congress moves forward with final FY23 funding legislation in December and into next year. Today, we are here to clearly state our community is not going away, and we need resources to fight MPV, and we will not rest until we succeed. In a moment, you will hear the latest status report from the front lines. STI clinics that are still bearing the brunt of a shocking increase, not only in sexually transmitted infections, but a continuing burden related to MPV. For far too long, medical professionals and health department STI programs have been forced to do too much with too little. That is unsustainable, and something needs to be done. We call upon Congress to take action on MPV funding, as well as an out-of-control STI epidemic. Later this year, the National Coalition of STD Directors will advance a new proposal to the Biden administration for an End STI Epidemics Initiative, otherwise referred to as an ESE initiative. This is modeled on the End HIV Epidemic Initiative that started under the Trump administration and has been carried through to the Biden administration. This plan must include an established and dedicated federal funding stream for STI clinical services that has parity with other proven programs like the Ryan White AIDS Care Act and Title X Family Planning Program. We need an all-of-government approach to fighting MPV and STIs, and it must include funding to support clinical services. We cannot fully end the outbreak of MPV. We cannot end STIs without a focus from our government and without the funding to get it done. Without further ado, I'd like to introduce my colleague, Naseema Shafi, who is the CEO of Whitman-Walker Clinic. Naseema, thank you.
Thank you, David. Good morning. As stated, my name is Naseema Shafi. I use she and her pronouns. I'm the CEO of Whitman-Walker Health in Washington, D.C. We're a community-oriented healthcare provider and a federally qualified health center. In our 50-year history, one of our oldest programs has been a walk-in STI screening and treatment program, where we provide care to thousands of unique individuals each year. We also care for about 3,500 people living with HIV, and overall provide services to about 20,000 unique folks each year. We've been responding to MPV since it arrived locally in the jurisdiction, and of course, preparing as it was emerging across the globe, working closely with local healthcare officials. The care challenges, communication challenges, and operational challenges have been enormous at a time when care teams are extremely frayed from the COVID-19 pandemic. Without any additional funding, we approved changes in staffing and new staff because crises can't wait. But constant investments are likely to mean that other priorities won't be accomplished. In terms of specific patient experiences, I want to share one aspect of the problematic themes from the clinic, and that this is something that we've seen from numerous individuals. We've had numerous individuals with debilitating genital or anal lesions who had previously been seen in other parts of our healthcare community, such as urgent care centers or hospitals. They were not properly diagnosed or supported in those settings. Some were misdiagnosed with herpes or syphilis. Some were not even tested for Mpox or MPV. And some went to places that didn't have the proper infection controls in place to test for MPV. Additionally, there are two critical messages that I want to convey to you in my time here this morning. First, competent, affirming sexual health care is under-resourced and especially under-financed. Places like Whitman-Walker step into the gaps, connecting dots across systems which are not well, with enormous amounts of red tape and process to ensure our communities get quality care. We do it without funding because it's our mission and it's critical for us. Not only is that unsustainable, but the decades-long divestment in sexual health further stigmatizes people and behaviors. It further enforces that sexual health is not primary care, and it is. Competent sexual health care affirms a person in their full expression and self, and that affirmation is key to nearly all other aspects of health and well-being. For us, sexual health care is an entry point into lifelong preventative medicine that our healthcare system so desperately needs. But it's not funded, or it's underfunded, or it's an afterthought. Second, any equity issue we believe we learned through the COVID-19 pandemic exists in this aspect of healthcare too. Underinvested in communities such as people of color bear a disproportionate burden when our systems don't accept that those inequities exist. We set up the same kinds of systems to access MPV vaccine across the country that were more accessible to people with flexible work schedules, people with more income, people with access to mobile devices or Wi-Fi. Equity means doing more, not doing the same. And to do more, we need more. I'm going to end my comments just with a deep sense of gratitude for my colleagues on the phone, my colleagues across the country, and my colleagues in the clinic for the work that they're doing. They do this out of a sense of duty and obligation, but it's rooted in a commitment to community. I'm really grateful for all of that. Thank you.
Thank you, Naseema. Up next is Dr. Shira Heisler, Medical Director of the Detroit Public Health STD Clinic. Dr. Heisler.
Hi, everyone. Thank you so much for having me. So just to introduce, I run the biggest STD clinic in the state of Michigan. We see the most STIs, and we have been the key center in the monkeypox response. So as came out a week or 2 weeks ago, clearly in the CDC preliminary data for 2021, syphilis and gonorrhea continues to increase. And now we have the current monkeypox outbreak. And once again, we in the STD clinic across the country are on the front lines. But we continue to have level funding despite the increase in cases and clinical work. So what does this actually look like on the ground? So managing logistics of distribution, coordination, and accessibility of the monkeypox vaccine in Detroit is a prime example of what the consequences are of lack of funding. So to start off, we were one of the key places, one of the 2 places in Detroit that got the monkeypox vaccine because we see this is our key population. Well, we didn't have any infrastructure for vaccine clinic, and there was eligibility because we had a shortage. So we had to do a monkeypox screening eligibility. Well, we set up a screening hotline. Well, initially, I, as a medical director, was literally answering all of these voicemails myself, which was hours. And this is in between seeing patients. Then this became completely unsustainable. And I was able to get 10 medical students. I trained all of them myself, and then they started doing this vaccine eligibility screening, which was amazing. But now they have exams, and I am back to doing answering these vaccine calls every morning. Another example of this, so earlier in the outbreak, when TPOXX was not as available, it was only physically available in 2 neighboring county health departments. I had a patient who was immunosuppressed, HIV positive, was in significant pain from monkeypox, and thus TPOXX was indicated. However, there was no way to physically get the TPOXX to the patient. The patient didn't have transportation, and my clinic or the neighboring county health department didn't have a courier service. So like physically, I physically couldn't get it for him. So I was going to drive there. Me and the epidemiologist were on the phone at like wee hours of the evening to figure it out. Somebody ultimately came the next day. But this is example. There's no infrastructure, organizational infrastructure to be able to do this. Another example was I work with a nurse practitioner. Again, TPOXX, it wasn't readily available. This was Friday afternoon. This patient is in severe pain from proctitis. And she came in on a Saturday afternoon to give him TPOXX because waiting till Monday is just not reasonable. So another example of what this lack of funding is, the main thing is staffing. We literally just don't have staff because there's no funding. So something that we have seen in the past 2 months, which was quite kind of remarkable, is the disparities that are already happening in monkeypox, right? So we have a significant people of color have lower rates of vaccination and higher rates of cases. So one of the ways to combat this was pop-up vaccine clinics. So meeting the most affected individuals where they're at, gay bars, ballroom events, pride events. All of these events occur at nighttime. Well, we don't have any funding or staffing. I can't pay overtime. So there was this monthly queer event at a local bar. We felt it was extremely important to get to the people we haven't been able to reach. I got 2 people from my staff. I collaborated with another LGBT clinic who got 2 people of staff. I myself am going, this is how we are doing it. This is the most grassroots effort, but it is unsustainable. All of us worked on our own time with no compensation. This event was quite successful with 37 people vaccinated and over 95% of them were people of color. So this brings me to my final point, is that when STIs continue to go up, and now we have the monkeypox outbreak, on the ground, we are stretched very thin. But we, as Naseema pointed out, have taken lessons from the AIDS epidemic, late 1980s, early 1990s. It was the LGBT community itself that fought and advocated for greater access to medication and research, and we are seeing that again. Myself and my staff are doing this all because if we don't, then our community will not get properly cared for and the health disparities will continue to grow. And this is just not a tolerable outcome. So just because we are a community that looks out for each other, this doesn't take away the responsibility of the federal government to take care of us. So thank you so much.
Dr. Heisler, thank you so much. Next is Dr. Kaiyti Duffy, the Chief Medical Officer for the LA LGBT Center. Dr. Duffy.
Hi, yes, thank you for having me. I agree so much with those sentiments. For us too here in LA, this has been a really challenging few months. We diagnosed our first case on June 24th. So that was about a month into the outbreak. Since that time, we've had over 200 positive cases. At one point, our patient population represented 20% of all that was in LA County. We've diagnosed patients in our primary care clinics, but our sexual health walk-in, where people tend to not need appointments and don't have to be established with us, has definitely borne the brunt of this outbreak. As the case numbers were rising in LA County, community members developing symptoms had very few places to turn. Very few clinics were able to offer testing initially because it all had to go through the county. People who are not our patients nor had ever been to our sites were calling our triage and on-call physician line, often petrified and describing terribly painful symptoms and telling us they had nowhere to go. For us, it wasn't a choice. This was our community, these were our people, and we were going to offer whatever testing we could, but we weren't prepared for it, and we didn't have the staff ready to provide this service. So just like With other FQHCs who are LGBT focused, our leadership had to step in. We had to be the ones that were answering the triage calls. We had to be the ones that were filling out the paperwork and sending it into county. One patient described to me that when he started developing symptoms, he went to a local emergency room because he didn't know where to go. He wasn't our patient. And he said that it was reminiscent of the early days of HIV. The doctor stood at the door and shouted to him, saying, "Show me where your lesions are." And they weren't willing to do testing. So that patient jumped in a cab and came up to see us right then and there and was a walk-in. And that happened on multiple occasions, people seeking care from other providers who were much more resourced than us, academic institutions, large hospitals, and they weren't able to receive it. When we began offering tecovirimet, the treatment available via compassionate use by the CDC, these numbers increased. People were desperate to get treated. Our staff have insurance that mandates that they go to the Kaiser system, and Kaiser wasn't offering it. We usually don't provide care to our staff, most of whom identify as LGBT. And so that was difficult as well. How do we provide for our staff community who may also be experiencing this and in need of medication? In our sexual health clinic, we used every single visit we had, also in our primary care. So this led to a backup in visits for STD treatment and PrEP starts and HIV diagnosis, and we're still only catching up. We also, when we were allotted vaccine, we also mobilized all of our leadership staff, particularly our nursing staff, to run vaccine clinics, giving about 200 vaccines in a day. But that left their posts vacant, and the work that they would do on a regular basis was ignored, unfortunately. During COVID, many clinics went through this. They were using their staff resources to get vaccine out, and the government recognized that and reimbursed them for that time and effort because they understood what this was taking from a community clinic. Though we've heard rumblings that that might happen here, it hasn't yet. And so there's been no reimbursement at all for the efforts that we've done to help this community. And I have no regrets. We would do this again, but it is overwhelming for a community clinic to take on an outbreak of this size without the support that we need from the state and from the federal level. Just in the same way as we responded to COVID, we have to do this here and now. Otherwise, it's institutional homophobia, and we want to call people on it. We need that support in mobilizing for this outbreak. I appreciate the time to share that. Thank you.
Thank you very much, Duffy. And I'm going to turn to Stephanie and Elizabeth now to facilitate questions from members of the press. Thank you.
Thank you all so much. A reminder that if you do have any questions, please raise your hand or please just put in your name and your outlet's name in the Q&A box. We'll give folks a minute. Ariel Cohen. Hang on 1 minute, Ariel. All right, go ahead.
Hello?
Hi, we can hear you now.
Great, thank you so much for taking my question. So David, I was wondering, now that monkeypox and COVID-19 funding have been excluded from the temporary funding bill, what do you think the next best chance of getting money for STI clinics is going to be? The White House has talked about reshuffling funds, making sure that everybody gets what they need. What does that look like to you when it comes to STI clinics?
Thank you, Ariel, for that question. There's two aspects of this that I'll comment on. First of all, under the leadership of the monkeypox coordinators out of the White House, Bob Fenton and Dimitri Daskalauskas, they oversaw a process to create temporary flexibility in funding mechanisms to allow for some reallocation of monies. That is only temporary. We still have a need for these additional resources. And so the second point I want to make is that we are looking toward the end of this stopgap funding measure called the continuing resolution, which it will expire December 16. I think, as most of you may know, this is about to pass the Senate if it hasn't already. A key procedural vote was held last night on a related to a matter that Senator Manchin wanted to advance. That was stripped from the bill. The CR will pass the Senate and the House. It goes through December 16. Our next opportunity to raise concerns around STI clinic funding, MPV funding, STI funding is in a final package of legislation that Congress will consider, which is called an omnibus bill to fund the federal government for the remainder of the fiscal year. So we will look to that omnibus bill to try to include funding there. If we're not successful there, we're not going to stop. We're going to advance proposals to the Biden administration for FY24, and we will continue our efforts to raise and to urgently make our case to the Congress in the next funding cycle. So I hope that answers your question, Ariel.
Yes, thank you so much.
Thank you, Ariel. Any other questions? I'll give folks a minute. A question from Ben Ryan with NBC. What is the timing of the omnibus bill?
So this continuing resolution goes through December 16. Elizabeth Finley's on the line. I believe that date is correct. The continuing resolution goes through December 16. That will reach the president's desk for signature this weekend. Once the midterm elections are finished, Congress must pass a final funding bill for the remainder of the fiscal year for those agencies that they have not finished the process for. So that is referred to an omnibus funding bill. The omnibus funding bill must be passed by December 16 if Congress doesn't take other action. One scenario is they could pass a continuing resolution for the whole fiscal year. A lot of this depends on the outcome of the midterm election and what happens post-election. But what congressional analysts are predicting is the congressional resolution, the continuing resolution will go through December 16, and then a final funding bill, an omnibus package of funding bills will be passed by that date for the remainder of the fiscal year.
Great. Thank you, Ben. Any additional questions?
There are some questions in the chat as well.
Great. Grace Tui with the LA Times is curious how clinics on the ground have seen the MPX outbreak affect STI care. Have there been any unintended consequences you all were not expecting? So I will open that up to the three of you.
I can start. I think the main thing is delaying care for things like treatment of gonorrhea, chlamydia, syphilis, getting people on PrEP. And the trickle-down consequences of all that, I don't think that we know yet. But anytime there is a delay in treatment or a delay in starting somebody on HIV medication or PrEP medications, there's a risk. Also, with the lesions that we've seen with the human monkeypox virus, there's skin ulcerations. And so that increases the likelihood of infection with like HIV or with herpes, with other STDs. So it's definitely increased risk, and it's postponed care, which is a very, very dangerous combination.
I echo that. I think also something that we saw is, being that we just have limited staffing, so we only can see X amount of people. Well, a lot of those people became you know, just as Dr. Duffy was saying, we were the only people early on that was testing, and so we were seeing all this monkeypox. So people, in particular, asymptomatic folks, they kind of got to the back because they were asymptomatic. Well, a lot of the STDs are asymptomatic. So I am confident that we were missing a lot of those things. And a lot of times people can come once and they're like, well, if I can't be seen today, I'm not going to come again. So I think that, again, we don't see the fallout yet, but I think that definitely was that. And I think PrEP is, for us, we do a lot. We are one of the biggest PrEP providers in the state. And again, because it's not as urgent, that got to the back of the line as well.
I would, Naseema, unless you wanted to comment, I just wanted to add one summary comment. Oh, go ahead. Through the work of, and through the research work of NCSD and CDC, it is well established that the COVID pandemic drove, because of disruptions to the STI care and treatment and research world, drove higher STI rates. We are very worried about and are assuming the same thing is going to happen in relation to monkeypox, and or otherwise referred to as MPV. As you've just heard, in terms of people experiencing delayed access to testing and care, we think the same thing is going to happen, and this is only going to make the STI epidemic worse in America. We are now in the 7th straight year of record numbers for sexually transmitted infections, with a shocking increase in the number of cases of syphilis. So this is a system that is stretched beyond the breaking point. People are not getting access to the expert care that they want and deserve to get through sexual health clinics, and is going to drive STI rates higher.
Thank you all. Amanda Seitz.
Hi, yes, thanks for hosting this. I just had a question. The White House has, we've asked about disparities in the monkeypox cases, has really pointed to some of its on the ground partnerships with clinics. But as Dr. Heisler just laid out, these situations sound like they're really dependent on volunteers. So I just kind of wanted to ask if that operation is really as robust as it's been made out to be.
But
Oh yeah, Naseema, you can answer that.
thanks. I'll go ahead. I think the reality in all of the programs that we run is we rely very heavily on different ways to fill staffing gaps. And so even our clinic here in DC, we do use volunteers for part of that work because it's unfunded and has been unfunded for decades. So where we can find volunteers to support, that's what we do. The majority of our team are full-time staff, but again, they're having to not do other things in order to prioritize those efforts.
Dr. Heisler, did you want to offer any other commentary as well?
Yeah, just to be clear, when we talk about volunteering, it's already our staff that's here, the minimal staff that we have, they're just working overtime with no compensation. That's kind of the issue, is that we're all just stepping up into these roles, and a lot of so just doing extra or not doing what we should originally be doing because this is requiring so much of us. So it isn't, it is volunteer work, but we're all regular staff employees just doing extra work.
I will just add that the White House Vaccine Equity Initiative is a robust initiative. It is making a difference. We are seeing numbers come down, but there is a price to be paid, as you have just heard, through the willingness of volunteers to step up, poorly funded local STI and sexual health clinics to step up, to partner in this effort. So yes, it's a robust initiative, but there's not enough money in it.
I just wanted to add that, at federally qualified health systems, burnout is a risk at baseline. And so you throw in this public health crisis in which there's this cognitive dissonance. You know, we leave the clinic being like, oh my God, this day, and everyone else was normal. You know, no one else was in crisis. And so it felt very isolating and alone for our staff. Whereas in COVID, everyone knew the pressure that medical professionals were under, and there was this acknowledgement, and we didn't have that. And so that's a very fast way to burn out even the most dedicated of staff. And the question is, you know, will we recover? Will they be able to regenerate and come back to us? And I don't know.
Thank you all for that. And thank you, Amanda. We have time for one or two more questions. This question's from Kristen Seamus from the Detroit Free Press. This is for you, Dr. Heisler. You mentioned that doses of TPOXX were distributed to neighboring counties, but not to the city of Detroit initially. Wondering whether you could elaborate a bit on the inequities of the monkeypox response that you're seeing in Michigan and in Detroit specifically.
Yeah, so this was right initially and again, there was a lack of, because there's a lack of funding, like on the state, you know, level, which I'm in touch with them weekly, and they're working their hardest. It's like there's operational things. So it initially just went to, in the area, went to Oakland and Washtenaw County. I do not know why it ultimately got to Detroit. But I, like, this was way early on. And again, like we should have been prepared because, you know, we just had a huge pandemic. We should have been prepared to how to be able to do this, but because this department of STIs has been so underfunded, we just, like, you know, kind of the head of the STI division on the state health department is working so closely with me on such a little level, like, to get this TPOXX. Like, I'm calling her. So I don't know why it didn't originally go to Detroit. I think Oakland and Washtenaw were probably better equipped to manage the distribution initially. But yeah, I'm not sure why that was, but I think that, like, there is the lack, this just to me demonstrates that lack of funding ultimately from the state level to the local level to these individual clinics. This is what it appears like. There's just lack of infrastructure to make these things actually work right away.
Great. Thank you so much, Dr. Heisler. I want to thank everybody for attending. I know there is the White House press conference at 11:45, so I want to make sure that everybody can make it over to there, but really appreciate everyone taking the time. And if you have any other questions, please reach out to our team. We will be sending out a recording of the press conference if any of you need it.
Thank you very much.